Thank you very much for this kind introduction, and thank you very much for the invitation. It's a fantastic place and a really well-organized meeting. So I hope you by latest mean the last 10 years, because not that much has happened very, very lately. So I'm going to talk about treatment of neuropathic pain and what is the evidence for this. And these are my disclosures. And as a background also for the next talks, I was also asked to give a little brief introduction to the classification of spinal cord injury pain, a little bit on mechanisms, and then I will go on and talk about evidence-based treatment and treatment recommendations. So I'm from the Danish Pain Research Center, which is located in Aarhus, as you mentioned, and it's pain research center that focus mainly on neuropathic pain, and I have had many years interest in spinal cord injury pain, and these studies are done together with our two spinal cord injury rehabilitation centers in Denmark, one in Viborg and one in Copenhagen. We're also interested in other types of central pain, central post-stroke pain, and pain in multiple sclerosis. And right now we focus also a lot on painful polyneuropathy due to chemotherapy or diabetes, and also post-surgical neuropathic pain. But today I'm going to talk about spinal cord injury pain. And one study that I like to cite is this study from Switzerland. It's a cohort community-based survey study. I believe it's ongoing. And this was a questionnaire study in subjects with traumatic and non-traumatic spinal cord injury. And the last question was a very open question: what causes you the most problems since your spinal cord injury? And then the ICF was used to code the results. And of almost 1,800 respondents, the most problem, or the problem that caused was most severe, was actually pain. So even over gastrointestinal problems and paralysis. So it is really a problem for many subjects with spinal cord injury. There have been many classifications of spinal cord injury pain over the years. In 2012 there was this consensus classification trying to combine all, and this was reviewed by major pain and spinal cord injury organizations. And it has 3 tiers. Here's the 2 first tiers. The tier 1 is classifying pain into nociceptive pain and neuropathic pain, other pain which don't really have a good name, but pain that doesn't classify these definitions. Some call it primary pain or functional pain, and then pain that's not possible to classify. When it comes to spinal cord injury pain, the most common pain type, both acutely and chronic, is musculoskeletal pain. It can be due to fractures, overuse, spasms, and so on. Visceral pain is very common, up to 30% in the very chronic phases of spinal cord injury. When it comes to neuropathic pain, it's divided into pain at the level or below the level of lesion. And then patients with spinal cord injury, of course, can also have other types of pain due to peripheral nerve lesion or diabetic polyneuropathy or central post-stroke pain. But the pain caused by the spinal cord injury is located at or below the level of injury, and I'll come a little bit back to that. In one patient, it's often difficult to separate these different types of pain. It may be in the same location. Some type of pain may aggravate other types of pain, and sometimes if it's a squeezing type of pain, is this due to spasticity, or is this neuropathic pain? And a visceral pain is sometimes difficult. In other cases where there's a diffuse pain from here and below, it's more clear that this is a neuropathic pain. Pain is common, as we saw in the Swiss study. This is a systematic review of cross-sectional studies where they find a point prevalence of about 55% of chronic neuropathic pain. This is similar to what we see in 2 prospective studies in spinal cord injury. When it comes to diagnosis of neuropathic pain, it's particularly difficult in spinal cord injury, I think, there are these criteria that has to be fulfilled, that we have to have a history of neurological lesion, the pain distribution should be explained by that lesion, there should be sensory loss, sensory abnormalities in the area, and there should be a test that confirms as a neurological lesion. But in spinal cord injury, almost all pains at or below the level of injury fulfills these criteria. So the challenge is to exclude nociceptive pain, which may be treated. The Canadian Pain Spinal Cord Injury Working Group is a panel that was formed to provide guidelines for the management of spinal cord injury and neuropathic pain in the rehabilitation setting. And they identify these red flag conditions that may aggravate a neuropathic pain, it may mimic a neuropathic pain, or it may cause a neuropathic pain. And this include musculoskeletal conditions, fractures, cardiovascular disorders, or often urinary tract infection can aggravate neuropathic pain. Patients may, of course, have other types of neuropathic pain, peripheral neuropathy, or they may have develop a syringomyelia. So every time there's a localized pain, a late onset, at least if it's after 1 year, or if it's aggravation of neuropathic pain, it's important to consider these. I think actually in spinal cord injury there's a more danger of overdiagnosing neuropathic pain than missing the diagnosis. When it comes to mechanisms, already in 1978, Melzack and Loza made this statement here that phantom body pain in paraplegic patients is the most mysterious of all pain phenomena. And they described these patients who had undergone removal of an entire section of the spinal cord and still feels neuropathic pain below the level of lesion. And I think even though we have a lot of studies and a lot of suggested mechanisms, it's still, we don't really know where the pain is generated. It seems that at level and below level pain are two different entities. At level pain, which is felt in the dermatomes at the level of injury, or below the level, if it's called equina, can be caused by both lesions to the nerve root, and then it's a peripheral neuropathic pain, or it can be caused by lesion of the spinal cord, while we consider below level pain to be a pain caused by the spinal cord lesion and the central pain. On a group level, at level pain has an earlier onset than below level pain, which can gradually develop up to maybe 12 months after the injury. And then there are two studies. We did one in Aarhus, and there's also an Israeli study that found that if patients have sensory hypersensitivity, so that they feel that the brush or cold stimulus is painful or unpleasant, it's a predictor of later development of below-level neuropathic pain, but this is not seen for at level. This predictor has also been shown in central post-stroke pain. So there seems to be different types of pain, but we don't really have any studies suggesting that these should be treated differently, except maybe for some surgical interventional studies. But even, say, for example, below-level pain, there are still different types of below-level pain. So even if we say patients with below-level pain might have different mechanisms and might respond differently to treatment. This is only descriptors, but there may also be psychosocial differences. For example, one patient may have just below-level gradually onset burning pain. Another patient may have below-level pricking pain and at-level evoked pain, or only at-level pain. Sometimes it's described as pressing pain. Some patients may only have evoked pain, for example, only cold allodynia is the only symptom, or which is common also in cord equine lesion, this shooting paroxysmal type of pain. So, of course, many studies we group these patients together because normally we don't have enough to do sub-grouping. But when it comes to understanding mechanisms and maybe also treatment, we may need to go into details and see which type of patients respond to which treatment. So I don't have time to go into detail to mechanisms, and if you look at preclinical studies, there's a range of different cellular and molecular mechanisms that are thought to play a role in why some people develop pain while others don't. I think that's a big question, because we can have two people with the same injury, one develops severe chronic pain and the other don't get any pain. So this is a schematic drawing of the dorsal horn of the spinal cord, the primary efferent, the secondary neurons, and we know there's a lot of changes going on with release of neurotransmitters, changes in different ion channels, calcium channels, sodium channels. There's a change in the state of the microglia, and they release various inflammatory substances and cytokines which change the excitability of the second-order neurons. There may also be differences in the descending pathways that can facilitate or inhibit pain, and we also see loss of interneurons in the spinal cord that release GABA and are inhibitory. And then there's a lot of structural changes with the reorganization and rewiring and sprouting. So all these changes are thought to increase the excitability of the secondary order neurons, and maybe also third and fourth order neurons, and probably also causes spontaneous activity, causing the pain to be felt below or at the level of injury. This also forms the basis of some of the treatment we use for neuropathic pain, tricyclic antidepressants, which increase serotonin, noradrenaline availability and increasing the inhibition, gabapentin and pregabalin, which inhibits the alpha-2 delta subunits of calcium channels, and different sodium channel blockers. So we know that a lot of changes takes place at the level of spinal cord injury, which are thought to be involved both in at level and below level pain. There are some early studies on DRESS lesions, and some studies suggested that if you extend the lesion high enough, maybe to 7 dermatomes above the spinal cord injury, that will also relieve below level pain, suggesting that this area is where the pain is generated. There are also studies that suggest that those who develop central pain are those who have are not so good at engaging that descending pain inhibition. So if you do tests and see how well they inhibit pain, those who have pain tend to inhibit pain less. The spinothalamic tract is also thought to be important. Most studies show that those who have neuropathic pain have loss of normal cold and warm sensations, but also studies suggesting that those who have pain have some preservation. They are what we call discomplete. So if you, for example, sensitize with capsaicin and then do a thermal testing, then they might have some response, suggesting that it could be ectopic activity in some spinothalamic tract neurons that are damaged but not completely cut or completely destroyed. And finally, several studies have shown changes in brain areas, and thalamus, and anterior cingulate cortex, prefrontal cortex. It's a bit unsure maybe whether these are part of generating pain or secondary consequences to lesions in the spinal cord. And there are also discussion about peripheral mechanisms in the peripheral nervous system. So a lot of mechanisms are involved, and they might be involved differently in different patients, but we don't have enough information now to say that burning pain is related to any specific mechanisms and so on. So when it comes to treatment, the neurosurgeons were those who originally took care of spinal cord injury patients, and also those who proposed treatments for pain. And this first one is a report of a successful case where they performed a prefrontal lobotomy, and you can see the explanation. The patient didn't complain anymore about the pain. Later, carbamazepine and phenytoin was available, but it was also noted that sedation and CNS side effects limited the treatment. And today we now have quite a number of randomized controlled trials, particularly in pharmacological treatment, specifically in spinal cord injury pain. And this figure is a way to try to summarize these trials. You see the drug here, and the red are those trials that are positive compared to placebo, and the size of the trials are relative to number of patients involved. So many very small trials. When it comes to antidepressants, there's one positive trial with amitriptyline and one negative, but not completely negative, but a small trial. It might be a type 2 error with duloxetine, which is a serotonin noradrenaline reuptake inhibitor. Pregabalin and gabapentin, positive in most studies. Then we didn't find an effect of lamotrigine, a sodium channel blocker. There's also no effect of levetiracetam, which is another anticonvulsant. There's agreement across various neuropathic pain conditions that this has no effect, and also no effect of valproate. There's a small study showing the effect of tramadol, a lot of dropouts, but still an effect on intention to treat, no effect of cannabinoids. And then there's one study where they gave botulinum toxin type A intradermally and found an effect. This study was published twice, and one of them were retracted. The other one is still there. It might be an okay study, but I think that's a treatment we really want to see reproduced before we try to suggest these peripheral type of treatments. It might be a bit difficult to understand. So when it comes to recommendations for the treatment of spinal cord injury pain, if we look at how many studies that are performed in spinal cord injury pain compared to neuropathic pain in general, is very limited, and there's no evidence to suggest that one type of neuropathic pain should be treated differently from another type of neuropathic pain. And the focus now more, maybe we should go for phenotyping classification instead. So NUPSIC, which is neuropathic pain special interest group of IAS, have a common recommendation for all neuropathic pain, so they don't separate in central post-stroke pain versus painful diabetic neuropathy, except for topical treatments. So based on a systematic review here, the first-line treatments are gabapentin and pregabalin, SNRIs, and tricyclic antidepressants. So this is similar to what we saw in spinal cord injury pain trials. And then there are some topical treatments that are only relevant for peripheral neuropathic pain, and tramadol is the second-line treatment, and strong opioids are third-line treatments. And then a lot of drugs, particularly these sodium channel blockers, for which there are inconclusive evidence. Some trials find an effect, some trials do not find an effect. And then some trials that are not effective, and because of also side effects are not recommended. I'll not go so much into neurostimulation. You'll hear much more about this. There was an update of the European Academy of Neurology systematic review, and there's very little evidence, and particularly for spinal cord injury pain. Psychosocial intervention, very important. When it comes to spinal cord injury pain, there's very limited number of trials available, unfortunately. This is a recent systematic review. I found, as you can see, only 11 trials, only 4 of them were randomized. The trials they included were educational, relaxation, mindfulness, and so on. There was some effect on short-term cognitive appraisal and psychosocial adaptation, but less effect on long-term pain intensity. But that's probably also not the best outcome for such trials. There's one study, I think it was very nice, by Cecilia Norbrink in Karolinska, and where they asked the patients what's your experience with pain treatment, what do you want when you come to your physician. This was in the rehabilitation unit, and many had resistance and fear of using pain-relieving drugs. They were worried about side effects, particularly that they would impact on the kidney function. And what they really requested was to learn more about strategies on how to cope with pain. And what they mentioned themselves was that warm baths, for example, avoiding stress, engaging in distracting activities, work, listening to music, and so on, was helpful. Also, physical activity, or mainly the balance between activity and rest. But they often felt that this was not offered by the healthcare system. I mentioned this Canadian pain spinal cord injury guidelines, and they made the guidelines based only on the trials in spinal cord injury. And so they're similar to the general neuropathic pain guidelines, except, for example, they only have amitriptyline as a tricyclic antidepressant. And if we look more general, it's a group recommendation, and there are antidepressants that are less sedative than amitriptyline. We use, for example, always imipramine, but it could also be other types of antidepressants that are less sedative. Then they have tramadol as a second line, that is similar to general neuropathic pain guidelines. And then the recommendation is lamotrigine for incomplete spinal cord injury. And that was based actually on a study we did back in 2002, where we compared lamotrigine, which is a sodium channel blocker and anticonvulsant, and we didn't see any effects of the drug compared to placebo, but we did some post-hoc analysis and found it was effective in those with incomplete injury. This has never been shown in a trial, so I think maybe it's a bit too premature to recommend this, but there are studies. We did one with oxcarbazepine, another sodium channel blocker, and peripheral neuropathic pain, with the primary purpose of seeing if it was more effective in those who had preserved thermal sensation and evoked pain, and it was more effective. So maybe sodium channel blockers do work in a subgroup. They also recommend transcranial diaphragm stimulation, even though there are few trials and some are also negative. It's very short term. And then the combination of visual illusion and transcranial direct current stimulation. This is based on a study by Soler, where they had this visual illusion where the patient sees his or her own upper body, but instead of the lower body sees a video of a person walking. And as you can see, there was no effect of either of the treatments alone compared to placebo, but the combination had an effect. And again, this is the only study, so would like to see more studies supporting this before putting it in guidelines. That's my own interpretation. So lastly, I just want to point out that there are not so many trials that are placebo-controlled. And I know it's difficult, particularly for intervention studies, but I think it's important, and just like to, I think I have the time just to briefly mention these two case reports actually by Ron Kubers and colleagues. So the first one is a patient with fatal back surgery, painful radiculopathy, who was referred for intrathecal opioid treatment. And at that time, before they did that, they had a placebo-controlled trial with epidural opioid. And this patient was randomized to placebo in the epidural catheter. So this patient came in with a pain intensity of 6.5, had placebo, and the pain went down to around 0 to 2. Patient had a pain diary. These are days. And then they gave some what they called placebo holidays. So they came in, they turned off the stimulation just to see if this was just the pain had resolved. But you see, when the patient knows that there's no more treatment, the pain increases again. And this happened another day. They also tried to give naloxone to see if it was opioid dependent, but it didn't have any impact on the placebo. This other study is case reports of 6 patients. They were all treated with deep brain stimulation, a thalamic stimulator, for at least 2 years, and they all reported moderate to good relief. and then these patients came in for a study. They were told to turn off the stimulator for 8 hours, and they were told that they would now get another type of stimuli. It's a new one. It could give paresthesia, but it also could not. And then they were randomized to active and placebo stimulation. They were reinforced by placebo suggestions, and they saw these graphs on a oscilloscope, so they had the feeling really that they got a stimulation. And you see the thalamic stimulation paradigm, the placebo here, the pain and dysesthesia before. Some effects, actually not significant, of thalamic stimulation, but also an effect of the placebo stimulation. And they even perceived paresthesia by the stimulation. Of course, they had neuropathic pain, they had some numbness, tingling, and so on. But seeing the stimulation, expecting it, many of these reported also paresthesia. So just to, I think, as it is for pharmacological treatment, double-blind treatment studies are important also for interventional treatments. I think that was my last slide, and I would just like to thank my collaborators and thank you all for listening.